to how to push down your throat. So the illness that you're screening for needs to be identified as an important health problem in society. Meaning, you see, when we look at population screening, you're looking at screening a large amount of people for a specific disease with a test. And it makes no sense to screen 12,000 people in 1 year for a disease when the incidence of disease in that population is very low. You understand? If you do that, you're going to be wasting resources. And you're going to be subjecting people to a test that's really not necessary. For example, say Japan. In Japan, gastric cancer is common. So they actually have screening for gastric cancer. Gastric cancer is not common in Trinidad or in the Western Hemisphere. And therefore, we don't have any screening programs for gastric cancer. You understand? You might end up having an individual screening situation with gastric cancer if your family had gastric cancer and there's a gene associated with it that you have inherited, and therefore they will screen you individually for the problem before you get it. You understand? That's different from population screening. So the illness has to be identified as a significant public health problem. The disease itself, there must be an established understanding of the nature or of the natural history of the disease, i.e., from how it starts, how it progresses, etc. So there must be significant science and study of the disease so that we know at what stage we should begin screening for this disease. Okay? The disease should have a recognizable latent or early stage. And the 3 cancers I mentioned, they all have that. Meaning, there should be a point in time when there is a condition that's not cancerous, that we can find the problem at that stage, remove it, and the patient is fine. And they are fine before the cancer even starts. You understand? The test should be acceptable and accurate. That's a broad statement. When we say this test should be acceptable, we mean it's important that the patient finds the test acceptable, or the individual. It shouldn't be a test that makes you too anxious or afraid to do. That's from the patient point of view. It shouldn't cause too much harm or injury on the individual, i.e. it shouldn't be too invasive on your body, okay, to make you not want to go and do it. The test, it shouldn't be too expensive, right? It should be relatively cheap. And to some extent, hopefully free. Right? And the test should be accurate in the sense that if you have a problem, the test should find the problem. Okay? I have to say, for many of the cancers, that test doesn't exist. And basically, we have to use the best of all of them. And there are many times when we start the screening, you may find something you're not sure, and it pushes you to do more tests. You understand? And that is a reality. Okay? Because nothing is perfect, other than God. All right. After you do this screening and something is found, there should be available an effective treatment option for the disease. You don't subject a population to screening and you find something and then there's no treatment available for it. That makes absolutely no sense. You're putting the person through unnecessary havoc, unnecessary emotional distress, unnecessary situation of knowing that there is something and I can't do anything about it because there is no treatment available. You might as well don't screen. Yes? At least you're going to have more years of not knowing and no, that is if there's no treatment available. Eh? You understand? Because at the end of the day, knowledge is power. Right? And if you know you have it, you could do something about it. Right? The test and treatment should be cost-effective, both on an individual basis and in the general scheme of things with respect to the country. Right? So that being said, there are clear advantages and disadvantages of screening. Advantages. Cancer screening may find changes in your body that could become cancer. i.e., it's not cancer yet, but it could become cancer. So that's an advantage. You could deal with it before it becomes cancer. Screening tests find cancer early, before you have symptoms. Meaning, you could have cancer because when you screened, you missed that period when it wasn't cancer yet. But at least when you screened, it was early enough before you had any symptoms, and you found the cancer early, before it spread. Because if the cancer spreads, well, that's not good. Right? Screening tests may help find cancer before it can spread, so you mentioned that. Disadvantages, these two points, false positive results and false negative results. Let me explain that. A false positive result is a result where you do a test, it comes back positive, but you don't really have the problem. So it could create unnecessary worry and anxiety. That could happen, okay? But that is still better than the other one. The false negative one is you do the test, it comes back negative, but you have cancer. You understand? That's worse. Because now the test comes back negative, and you think you're good. Until time passes, and by the time you realize that the test was wrong and you really have something, it might be too late. Because now you're having symptoms, it's spread to other organs. And once, I'll mention this now, once the cancer has spread from one organ, the organ of origin, to another organ, that's considered stage 4. And I know you're all familiar with that term, stage 4, right? That means it has spread to other organs, and the cancer is going to multiply in those organs and affect the function of those organs. Okay? Although you'll be going to a better place. But, but you know, as a consolation. But at the end of the day, you know, we still want to be on this earth as long as we possibly can, to be with our loved ones and so on, right? And enjoy the spoils that the Lord has given us. Yes? Yeah. So let's go into a little bit of the individual diseases. Breast cancer. Breast cancer is very common in the world and in Trinidad. It's the second leading cause of death amongst women. And we see too many of all different age groups. I don't know why. It's more common in that general population, sporadic, as opposed to genetically caused, but we do have a fair amount that's genetically caused as well. So let's talk about it a little bit. So breast cancer is a malignant tumor, which develops from cells within the breast, right? Basically, any tissue in the body can become cancerous, okay? From skin deep to as deep as bone. And within the bone marrow, you can develop cancer. Okay? It may invade healthy tissue nearby or go towards the lymph nodes. Those little green things on the picture there. Picture, you see the breast far away, and the other breast is cut what we call sagittally, this way. So you're looking at it from the side, right? So you can see lobules at the back leading to ducts, and the little red beans there is representing the cancer. And cancerous cells can spread from that lesion into the lymphatic vessels, into the lymph nodes, and find its way into the bloodstream, and i.e. get into other organs. And that's one of the routes of spread. It can be presented in two forms, either invasive or non-invasive. The ideal way to find it through screening will be the non-invasive way, meaning it hasn't penetrated certain membranes to find its way into these vessels, blood vessels and lymphatic vessels and so on, and that's why it's considered non-invasive. And that is the point where you want to get it and remove it, you understand, to avoid any long-term effect. So the invasive type is cancerous, it's malignant, and it has potential to spread to other organs. The non-invasive type is pre-invasive, it is still in its original position, and it eventually develops into invasive breast cancer. So it's not cancer yet, but it definitely will develop into breast cancer. That specific one is called DCIS, ductal carcinoma in situ. That is what the abbreviation stands for. The thing with ductal carcinoma in situ is, okay, how to put, some doctors may say it's not cancerous. They might say it's precancerous. That is true. I tend to say it's cancer, because it will eventually turn cancer. I might be wrong. Why? Because the insurance companies don't look at it as cancer. If you have health insurance and you develop ductal carcinoma in situ, and you go to the insurance company for benefits, which you've been paying towards for all these years, they will tell you, no, sorry, you cannot get anything because it's not invasive cancer. So I'm not saying that you will hold on to the pre-invasive cancer until it becomes invasive to go and get things from the insurance company, right? But that is the reality. The only way they will pay out on your claim is if it's invasive carcinoma. So screening for breast cancer, studies have shown that mammograms are the best way to find breast cancer early, when it's easy to treat. Now remember, I mentioned earlier that there's no perfect test, but mammogram is the best one. Based on, it's not too invasive. Yes, I know a lot of women hate it because of how it squeezes the breast. Some women have more tender breasts than others, and when you put the breast between the plates and it squeezes to do the X-ray, it tends to be very painful. But nowadays the technology is improving, and they have digital mammography where the squeezing is much less, and most of the centers throughout Trinidad and Tobago have these machines now. Okay. Mammograms may find breast cancer tumors before tumors can cause symptoms or be found during a breast examination. And remember, as I mentioned, once the mammogram finds the lesion, that's when everything starts. Number one, the mammogram doesn't confirm that it's cancer. Okay? You still have to do other things afterwards to confirm and then treat. Women who are 40, so this is, breast cancer is a condition where age is the deciding factor of when screening starts in the general population. So once you turn 40, you are considered of average risk of getting breast cancer based on age, and that is when you should start getting screened. If you're between 40 and 49, people should have annual mammograms and breast examinations. So it's not just the mammogram. There are times you may actually have a lump that you can't feel, but the doctor, because of his experience, could feel it. And the mammogram may not pick it up. And this is where you could get a false negative mammogram result. You understand? That being said, amongst all the tests, the mammogram is the best screening test because of the criteria, because of all the different aspects of what a screening test should be able to do. Okay? And that is why screening involves the mammogram as well as examination by the doctor. Your primary care physician should be able to examine the breast for you and teach you how to examine yourself. So in between, you do self-breast examination. Self-breast examination is not equivalent to the physician examining the breast. Doing the mammogram alone is not screening. It involves mammogram and breast examination by the physician. So people should have annual mammogram and breast examination between 40 and 49. Some healthcare providers may recommend the mammograms every 2 years, which is fine. Once the woman reaches 50 to 74, your healthcare provider may decide to do the mammograms every 2 years. So he will examine you every year, but you do the mammogram every 2 years. Some providers may use breast MRI tests to screen someone who inherited genes that increase their cancer risk. That situation will arise because the woman who inherited a mutated gene, like the BRCA gene, for example, she's at risk of developing breast cancer at a much earlier age, in her 20s, 30s. During that age, the breast tissue tends to be very dense. So the mammogram, there's a higher chance of the mammogram missing things, missing lesions in the early stage. And that is why it's preferred that they get screened with MRI. MRI scan is not the best screening modality for the general population. One, many times you have to use intravenous medication, which is a little more invasive than just the mammogram. Two, it's expensive to do, right? And three, it takes a lot longer to do. So to screen the general population with a test like that, it doesn't make financial sense. That being said, there's one country in the world, I think it's New Zealand, who recently banned mammography. And I imagine they are doing only MRI screening for their population. They can afford it. So this is just an example of a mammogram machine in a diagrammatic format, where the woman is placed between the plates. It's done at two different views, each breast. One is called craniocaudal. It's when you see CC, you press the breast like this, and the other is oblique mediolateral, is like that. Mammography is the process of using low-energy X-rays to examine the human breast, and is used as a diagnostic as well as a screening tool. I'll pause on this a little bit. So screening is where you have absolutely no problem, obvious problem at least, and you go and you subject yourself to a test to see if there's a problem. Diagnostic is different. Diagnostic is when you have a problem. You have a lump in the breast, for example, and it needs to be investigated. So mammogram is the first step in investigating the lump. So you do the mammogram, you have to do the mammogram to check that breast to see what the lump looks like. to see if there are any other lumps in the breast, that same breast that you can't feel, or if there are any other lumps in the other breast that you can't feel as well. And it's from that point in time, you go on then to do biopsy and so on. The goal of the mammography is the early detection of breast cancer, typically through detection of characteristic masses and or microcalcifications. So I'm mentioning things here that you're going to hear, as time goes on, so you have an idea of what they're talking about. That slide shows 3 mammograms. The one on the far left is a normal mammogram, it's obvious. The one in the middle is assumed to be a benign cyst, which is non-cancerous. You can see how the margins is smooth and so on around it, and is well defined. That being said, sometimes there are lesions that look similar to that on the mammogram, and they are ignored. And 2 years down the road, the patient gets to find out that it was actually cancerous. That happens. So my motto is the best breast lump is the lump that's not in the breast. Right? If it has a lump, we should take it out. Before we take it out, we have to do certain things to make sure we have an idea of what it is. So the first step is a biopsy. All these tests are guides. Okay? They guide us to something else. Even when you do the biopsy and it comes back benign, I say, Ma'am, hear what? I think the best thing is to still take the lump out. The biopsy in itself is a guide as well because it's a representation of the lump. It's a piece of it. It's not the whole lump. You could have taken a piece of it there and that part isn't showing what's wrong, and another part has a problem. You understand? Yeah. So just take the whole thing out. The reason why, and then you might say, so why do you just take the whole thing out and done? Why the needle biopsy? Is because the needle biopsy, again, helps guide us towards how much we need to do. Because if the needle biopsy says no cancer seen or no pre-cancer seen, then the surgery we have to do is much simpler. It's a smaller cut, a smaller area to remove, less cosmetic problems, etc. If the needle biopsy shows a cancer, then we not only have to remove the lump, but we have to remove normal tissue around the lump. It may coincide with a situation where the ratio of the lump and the size of the breast may be such that removing the lump and extra tissue might deform the breast too much. You understand? So we may have to think of doing fancy surgery to make it look good, right? Or do something major and reconstruct at the same time, or plan reconstruction later. And not only that, if it's cancerous, we have to remove a few lymph nodes to send to tests. So when you go to the doctor and you say, just take out the lump, that's not the right thing. Because when he does that, he's burning bridges in terms of what to do in a general sense. Because the best time to do what is needed is at that first instance when we do the surgery. If the needle biopsy, simple thing, shows cancer, when you go to do the surgery, as I mentioned, you have to consider the margins. If you don't have clinically involved lymph nodes, there's a procedure you can do to just sample the lymph nodes, which would involve putting dye in the breast, getting the dye to go to the nodes. If you would have cut around that and interfere with those channels, then you can't do that anymore. Then you have to do more dissection in the axilla to get the lymph nodes. You understand? So there are a lot of things that needs to be done while the lump is there. Okay? The ultrasound. Breast ultrasound is not equivalent to mammogram. People have to stop saying, I don't like mammogram, I want the ultrasound instead. It doesn't work that way. It's not the same thing. Ultrasound is very user-dependent. What does that mean? It depends on the operator who is doing the ultrasound and seeing what they're seeing and writing it on the paper. You understand? The mammogram, you saw the picture before, everybody looking at it will see the same thing. You understand? Human error is evident. People make mistakes. So someone could have a problem, and the ultrasonographer doing the ultrasound could miss it, as well as they could very well see it. I'm not, okay? However, the ultrasound is indeed valuable. So you might ask, so how come when after the mammogram they send me to do the ultrasound still? But that is because it's possible that with the mammography, the tissue was so dense that the chances of missing something was significant. Okay, so they will deem that mammographic test incomplete and suggest that you do an ultrasound just for completeness sake. So at that point, they send you for the ultrasound where they take them time and go through the breast to see if they see anything abnormal, basically. And also, the ultrasound is a valuable tool in helping guide the biopsy. Right? So while you're actually looking at the lump with the ultrasound, the needle goes in and you can actually see the needle going through the lesion, so you're sure you're getting a proper representation of what it is to send to the lab. The breast MRI. MRI uses magnets. I hope you all have time, because this, as you can see, I still have 2 other cancers to go through, so it's going to take some time. Okay? All right. If you get bored and fed up and you want me to shut up, I will just say. All right. So MRI scan uses magnets and radio waves. It creates cross-sectional images of your body. As I mentioned earlier, it tends to take long. It's used to view areas of concern found on a mammogram. But as I mentioned, there are some places where they stop doing mammogram. And some centers, everybody who has a problem gets an MRI, but it's not absolutely necessary to do MRI all the time. It has its indications. The patients must lie inside a narrow tube, face down on a special platform. So if you're claustrophobic, that could be a problem. Okay? The platform has openings for each breast that allows the images to be taken without pressing on the breast. So women who are fearful or can't tolerate the pain that's caused by a mammogram, then we advise them that you can get an MRI. You just know that MRI many times is not readily available in the public sector in Trinidad, and you may have to pay for it. And it's, I don't think it's readily available in the public sector in any of the islands in the Caribbean. At least in Trinidad, there are some institutions where you can still get it, free of charge. St. James recently got an MRI machine, but unfortunately, they didn't buy the coil for the breast. Yeah. But you can get it done at Eric Williams. You can get it done at Arima Hospital. So there are places where we can get it done. The bad thing about that is when you have to go from region to region, it becomes a bit stressful. You know, you have to beg, a favor, and people complain and all sorts of stuff. You don't want to, if you write down your questions, or you try and remember your questions at the end, at the end you could give me your questions and I'll answer. All right, go ahead. Yeah, they need a mic. Somebody need a, just now. Yeah. Yeah, that's it.
You're saying now the MRI free, right? That's what you say, right?
In some institutions, once it's available in a public institution, it's free.
Yeah, but public institutions don't have it. Major.
Once it's available in a public institution, it's free. Thankfully, in Trinidad and Tobago, our public system is not a mixed system. It's not, once the service is available in the public hospital, it's free to residents of Trinidad and Tobago.
Yeah, but then they have you on a waiting list.
Regardless.
A lengthy waiting
No, that's
list.
a different thing, partner. Regardless to what the circumstances are, with respect to you getting the investigation or the treatment, that's a different story. The fact is, it's available. Available doesn't mean you're going to get it in a timely manner.
But as the same thing I say, you're on a waiting list.
But it's available and it's free.
All right, no sin at all. But that's it.
That's a different topic. I agree with you that it should be better. And I agree that there are things that can be done to make it better. Why it's not being done to make it better, I don't know. All right. So this is I allowed you to ask a question because you were adamant. But I think I will stick to questions at the end. Right? Otherwise we will never get through this thing today. Okay? So questions at the end. So this is what a picture of an MRI scan looks like. Okay? And you can see the detail is much clearer compared to the mammogram. All right? That being said, the MRI scan also has a tendency to overread things. So you could, and hence lead to more unnecessary biopsies, for example. Right? So depending on what your biopsy results show, when your breast cancer was found out or discovered, depending on the biology of the cancer, so they have to do special tests on this little sample that they take. That will dictate whether you are a candidate for one or two, most times it's at least two of these treatment options, or even all of the treatment options. And that is all dependent on the biology of the cancer. Okay? And one thing with that biopsy results, negative isn't always good. Okay? For example, the receptors that we do. And another big word, Pastor, immunohistochemistry. When we do that on the sample, we're looking for receptors to look at the biology of the cancer, and that is done to help guide treatment. If it's triple negative, that's bad. It means the only thing we can treat you with is chemotherapy. And many times, the chemotherapy, depending on the size of the lump, etc., is given before surgery. So chemotherapy first, you finish all your cycles, and then surgery. Right? That's just an example. Don't think because I said all negative means bad, that doesn't mean all positive means it's all that good either. Because if you have all positive, you still have to get chemotherapy. Because of the HER2 being positive. You understand? The best thing it could be is ER/PR positive, that is 2 positive, and HER2 negative. That is the only opportunity you can have to possibly get away from needing chemotherapy. Right? I know a lot of people think, oh, but I ain't want no chemotherapy. But yes, it is difficult. It's not easy. But as I tell my patients, you see how the chemotherapy is making you feel? It's making the cancer feel 100 times worse. Push through it. You'll get through. And most of them do get through. I would say at least 98% get through. Right? They push on, they suffer through it, and many times it pays off. So let me just mention them. Surgery, radiation therapy. Radiation therapy, once we're dealing with curative intent, usually comes after or everything else, other than the tablets that you have to take for 5 to 10 years. If you have ER/PR positive, which is the good thing. The biologic therapy, that is dependent on the same biological thing, the immunohistochemistry. If the HER2 is positive, that is when you're a candidate for that therapy. Hormonal therapy is really hormonal blockade therapy because they give you a treatment to block your own hormones, okay, or to block the receptors that your hormones are going to affect. And well, chemotherapy. So as I said, the treatment depends on multiple factors: the type and stage of the cancer, the sensitivity of the cancer to certain hormones, the medical history and overall health of the patient. Because a patient may be a candidate for chemotherapy, but they may not be able to tolerate it because of other illnesses they may have. The age of the patient. So, for example, a 90-year-old woman who comes with a breast cancer, most likely she's not going to be offered chemotherapy. Okay? In fact, she may just be offered an operation under local anesthetic to just remove the lump before it grows more. You know? And this is one disease where the patient preference matters a lot. A woman has a say with respect to her breast. And I have come to see and realize that people differ broadly in the way they think. One woman will come into the office and she may be a candidate to have the breast removed because that's all we can do because of everything. And she will be adamant that she doesn't want her breast off. She prefers not to live than to remove the breast. Seriously. And the next patient who comes in will say, take off both of them. Yeah, and that patient is a candidate to have a breast conservation surgery. Because simply remove the lump, remove the nodes, you do your medication, you get your radiation therapy. Once you save the breast and it had cancer, you have to get radiation therapy. Eh? Let me mention that. Okay? Right. And they say, no, I don't want it. Take it off. So, and this is when I have to counsel and explain that there's no survival benefit in taking off the breast. When you compare both, the survival is the same. In some studies, they actually show where the survival benefit is worse if you do a mastectomy as opposed to saving the breast. Yeah. And you know why? Sometimes because the human being is also a psychological being. And it affects a woman psychologically significantly. And when you get psychologically affected, the biology becomes affected. You understand? The social implications is affected. Because whereas before you thought your husband would love you still, after you take off the breast, you went and get somebody else. And you get depressed. You understand? So it's multifactorial, you know? So it's not an easy decision to make. But a woman has a say with respect to whether the breast stays or it goes. If you want something and we can't offer that to you because of obvious reasons, we tell you, we explain to you, and you take it from there. Okay, so we're coming towards the end of the breast session. This is a case here with a young patient. She was in her 30s. As you see in the far left, that's when the precancerous lesion was there. She didn't actually have invasive cancer, right? And it's this patient who led me to learn that the insurance companies don't cover pre-cancer because she had insurance. And when she went to claim afterwards for her benefits, they said, no, sorry, you don't have invasive cancer. But you see where the green marks are? Almost the entire breast was filled with tumor. I was surprised that it came back as precancerous. It probably grew fast because of the hormonal changes that was occurring during her pregnancy. So she was pregnant at the time. Look at the belly there, right? So she was actually pregnant. So we had to wait until the baby was term and do a C-section, deliver the baby at 38 weeks, and at the same time, do the operation on the breast. Up on top, you can see what we did was, because of how multifocal and multicentric the lesion was, I did a nipple sparing mastectomy. So we saved all the skin on the nipple of the breast and removed all of the breast tissue. And at the end, reconstructed her with an implant. So the photograph so the picture below has an implant. So the breast with the implant is actually a little more perkier than the other one. But she's okay with that. And so is he. And to put the icing on the cake, she got pregnant again after that and had another baby. This patient here, as you can see, there's signs that there's a lot of weight loss, right? A lot of weight loss. Her weight loss took place not because of the cancer. She had developed like a food phobia, fear for food, because she was afraid of getting illnesses. She stopped having milk, eggs, meat, cheese, everything. She was only eating vegetables and beans and not even rice. She did provisions, you understand? And provisions that she grew. She didn't buy anything in the market. She lost a lot of weight. And lo and behold, still developed a breast cancer. So she came to us, and you can see on the right breast, so it's the left breast, but on the right side of the screen, you can see a raise in the skin there. So that's where her cancer was. So we saved breasts, removing the cancer from that side as well as the lymph nodes, and did a similar operation on the other side. And that was her result. This is 1 week after the operation, and that's how she was. I was able to convince her to start back eating exactly meat, cheese. Well, she didn't really go back to the eat. She went to fish and eggs and so on, and she put back on some size, and she healed well. Okay. So let's go into cervical cancer. No, she was already postmenopausal. She had passed that age. So the National Cancer Institute says that the use of pap smear tests to screen for cervical cancer has resulted in fewer women being diagnosed or dying of cervical cancer. Everyone here knows what cervical cancer is, right? Okay, not this neck, eh? Okay, the neck of the uterus. Okay? Okay. So there are some guidelines associated with screening for cervical cancer. Screening should begin at the age of 21. I think the age of 21 came about with regards to the American age of legal adult, when you're able to make decisions on your own, etc. So no one should be subjected to any tests before they reach that age. And I think that is where that age group came about. In my opinion, once a woman is sexually active, she should get screened for cervical cancer. She should do pap smears. So if you start doing that as a teenager, mommies, advise your daughters. You're not supposed to, but honey, things happen. Things happen, right? And if it's happening, advise them to come with you when you're going to the doctor, family planning or whatever, and get your pap smear done, right? Even if they're not 21 and they're doing the business, that means they're old enough to go and get screened. Right? Okay. So females ages 21 to 29 should have pap smear tests done every 3 years. Women ages 30 and older should have pap smears done together with an HPV test every 5 years. HPV is a risk factor for cervical cancer. However, if you have HPV, that doesn't necessarily mean you will definitely get cervical cancer. And if you had cervical cancer, it doesn't necessarily mean it was because of HPV. There are over 100 forms of HPV out there. Many of us have HPV and we don't even know it. Okay? It's acquired mainly from sexual contact, even touch, kissing, etc. And as I said, it's not treatable. Your own body develops antibodies against it. It cannot be treated with an antibiotic, okay, because it's not a bacteria, it's a virus. All right? It usually takes about 2 years before it's cleared from your system, right? But it's one of the main known risk factors for cervical cancer. Some healthcare providers often do HPV tests and pap smear tests at the same time. People in this age group who don't have HPV tests should have their pap smear done every 3 years. So if you're above 30 and you're not doing the HPV test, you should do the pap smear every 3 years instead of every 5 years. So I have to, because of this HPV thing, I have to talk a little bit on the HPV and the vaccine. The vaccine protects against several HPV-related cancers, such as cervical cancer, penile cancer, anal cancer, smooth mouth, some mouth and throat cancers. So yes, men should also get the vaccine. Right? It's not only for the woman, it's also for the man. Same age group. HPV vaccine is available in Trinidad and Tobago through the Ministry of Health expanded program on immunization, and it's free. The Ministry of Health recommends that the vaccine be given to individuals up to age 26. Once you're between 9 and 14, the vaccine is given as a 2-dose series. Between 15 and 26 is given as a 3-dose series. If the patient is immunocompromised, they get the vaccine as a 3-dose series from age 9. And that's what I'll talk about on cervical cancer. So you are aware. All right, colon cancer. This one will be a little more elaborate. Screening recommendations for colon cancer. Once an individual approaches the age of 45, they are at average risk of developing colon cancer. Okay? So again, this is a classic cancer that fits all the criteria and all the characteristics that I mentioned earlier on. There is a precancerous stage, meaning you can find a problem that can lead to the cancer and deal with it. Okay? There is the hereditary aspect of it, and there is the sporadic aspect of it. Meaning, just because you reached a certain birthday, it means you are more risk than the younger population of getting colon cancer. The list of tests I have there are tests that's considered for screening. Again, consider all the criteria that I mentioned earlier with regards to what the test should be like. The cheapest test is the first one. Okay? It's an annual fecal stool test looking for blood and or genetic mutations in your stool. The next one is a flexible sigmoidoscope. That one only looks at the if I say distal, you'll understand what I mean? Distal. Okay. Okay, that means the latter part, the end. Okay? So it looks at the 1/3 end of the colon and the rectum. So some people may decide to do the flexible sigmoidoscope, looking at the distal end, together with the blood test in the stool to cover the right side of the colon. Because it's known that lesions on the right side tend to bleed more, and lesions on the left side tend to obstruct more, right? Rather than bleed. Colonoscopy is offered every 8 to 10 years. Double contrast barium enema is offered every 5 years. CTC stands for CT or computer tomography coronography. That has been endorsed to be a suitable screening test. However, the timing of repeat is still uncertain. Now, after I've gone through all of those tests, I'll tell you, if you do any of them, specifically the annual fecal stool test, the flexible sigmoidoscopy, the double contrast barium enema, the CT and coronography, if a problem is found, you have to go and do the colonoscopy. You understand? Therefore, colonoscopy is the gold standard. It depends on where you go. Colonoscopy is available in the public sector, but to get it done as a screening tool is almost impossible. Because of the workload they have to use the facility for people who actually have something, right? As I said, the fecal occult blood test is easy, cheap, etc. The colonoscopy is expensive, right? So from a screening tool, where cost is considered, it may not be the best test, right? And in some places, a colonoscopy is about $5,000 TT. The key goals of colonoscopy is to visualize the entire colon. So that's why I said, if you do the sigmoidoscopy, which is only looking at the distal third, and something is found, you still have to go and get the colonoscopy of the rest, because you can have something called a synchronous lesion, meaning you have one on the left and you have one on the right too, right? It's done to identify and remove polyps. So if you do a CT coronography and you see a polyp, the polyp may not be cancerous, it may be pre-malignant, but it shouldn't stay there. So you still have to go and do the colonoscopy to remove the polyp. The major barriers of colonoscopy, as we've been mentioning, cost, the fear of the procedure, especially men have this phobia about having things go up the back passage, and some women too. But these days, technology has it that the colonoscopes now that they use are much thinner. And in fact, it's really a test that's not difficult to tolerate. You don't necessarily have to be put to sleep or even sedated to do the test. Yes, it's a little uncomfortable, but, for the better part, it's quite tolerable. And the bowel prep. To do a colonoscopy, you have to do a bowel prep. So the day before, they give you this regime to follow, to purge you out. And so some people, that could be a bit much. But that's one of the invasive aspects of doing this thing. But if you realize all these tests that you have to do, if you choose to do those, require bowel prep. The only one you don't have to do a bowel prep for is the fecal occult blood test, because you're passing stool and doing tests with the stool. You understand? Everything else here, once it was scoping to look for things, or doing a barium enema to look at the x-rays and so on, to see, the bowel has to be cleaned. Okay?
Let me just ask a quick question as you hear. You see a lot of these like front office people offering all these colonoscopies and whatever. Are they allowed to do that? Is it so? It's not through the hospital system. Everybody have a store upstairs somewhere, and they come and take a screen and.
Well, they're advertising the business.
So is it legal?
Yes, it is legal.
Okay, all right.
It is legal. It is legal, and at least it's offered, because quite frankly, the state. I'm afraid to use the word government now. The state doesn't offer screening. The state doesn't offer screening for anything, including breast cancer. You understand? Because, so what we really practice in Trinidad is more individual screening, not population-based screening. In 1 year, we're not going to take everybody who is 50 and say colonoscopy, right? Because that's going to be 12,000 colonoscopies for the year, which means about 500 colonoscopies a month in every institution. You understand? Which means about 100 colonoscopies a week. You understand? So that ain't happening. We don't have the resources for that. It could happen, but it requires a lot of effort and drive, Yeah. So this is a video of a colonoscopy. The image on the right-hand side depicts the trajectory of the colon. Towards the end, I'll show you another image to describe some other aspects of it. But you can see from the beginning, you have the cecum, and moving from right on the patient to their left side, or left on the screen to the right of the screen, you go in the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and then the rectum in the middle. So in a colonoscopy, you enter the rectum, and there's a lot of maneuvering, because if you look at the diagram on the other side, you can see how many curves the colon has, right? And twisting and turning. So the endoscopist has to maneuver a lot of turns to find the lumen and continue his scope. So this patient had a very good bowel prep, because you can see the wall, you can see the vessels in the wall of the colon. The liquid in the bowel is pretty clear, as opposed to seeing brown stool stuck up, and then you can't really do a proper test, right? So there he's maneuvering through the colon, probably at the splenic flexure here, to get into the transverse colon, and working his way all the way across towards the hepatic flexure, which is on the patient's right side, to eventually enter into the ascending colon. And this test ends when he reaches the cecum, which is the beginning of the colon. When the test ends, that is as far as he'll go. So this is transverse colon here still, and they wash and suction. So here you're actually coming backwards, and this is where you do the actual examination of the bowel, when you're retracting the scope. So as you retract the scope, that is where you could take your time and see everywhere properly, and you look at it in a circumferential manner, making sure you're not missing anything. And you do that all the way back to where you started, which was in the rectum. And when you reach the rectum, we do what is called a retroflexion. So right now, a retroflexion is being done, and you see where the scope is entering the anus. So this patient has a couple hemorrhoids there that they could see, right? This is another video. Let me hear Mike Pastor that actually has audio, so you listen to it from here. You're here. Oh, yeah, raise your volume. You're coming to the TV. You can raise the volume on the TV. Yeah, go up all the way. Nice.
So we're pulling the colonoscope back through a normal, healthy colon that's very well prepped, and you see this bump that just is sitting on top of a fold here. And this is a large polyp at the splenic flexure, which I'm going to look at now with the scope, and we're turning a blue light on, which is known as narrowband imaging, which allows us to see the surface pattern with more detail. You can see the surface has a villiform or a stripe-type pattern, which suggests that this is probably an adenoma, which is the type of polyp that may have the risk of turning cancerous. And this is the type of polyp that we want to look for in a screening exam and remove. By removing a polyp like this, you prevent it from ever having the chance of turning cancerous. This polyp causes no discomfort, and the patient has no idea that it's even in there. The white catheter that you see that's coming out is actually coming through a channel in the scope known as the biopsy channel. And it's being used right now to just investigate how this polyp attaches to the wall. And what you can see is that the polyp is attached by just a little bit of normal tissue, what we call a little stalk. And we're going to use this snare, which is a catheter that has a loop of wire around it, to extend the wire out around the base of the polyp and then put electric current through that wire. You see the wire coming out now, and it's been surrounding the bottom piece of that polyp. We're going to now close that snare, and the patient feels nothing of this as this is being done. There's absolutely no nerve endings there. Now, electric current is going to be put through that snare, and you're going to see the polyp start to turn purple and fall off. The reason it fell off is that the wire cut through the base and cauterized at the same time that it cut, so there's no blood or bleeding. We're using a water jet now to irrigate or wash that area where the cut had been made, and as you can see that the tissue looks completely normal and healthy there. So it's been completely removed, and we'll send the polyp to pathology.
So no, it's not a hole. So what you're seeing there is just, the colon, the intestine is made up of different layers. Okay, you have the mucosa, the submucosa, the muscular layer, which is usually 2 layers, circular and longitudinal, and then you have the serosal layer. So what's being cut there is just the inner lining, which is the mucosa, which is where the polyps start from. Okay? So making it easy to find the problem and remove it before it becomes cancer. Okay, so I'll try and go through these other couple of slides a little faster because these wouldn't be with respect to the average risk patient, the general population. However, there is an increase of moderate risk patients, and this is due to personal or family history of colon cancer or adenomatous polyps. The timing of the colonoscopy screening varies, and it's based on the individual's clinical situation, right? These are the 3 situations that will dictate that. If a patient had 3 to 10 adenomas, so for example, that same colonoscopy you saw there, if that patient had 3 or more, then they will be required to have a repeat colonoscopy in 3 years' time after it is removed. If it's 1 adenoma that's larger than 1 centimeter, same thing. If the adenoma was a high-grade dysplasia, because when we take it out, we have to send it to the lab to test. And if it comes back with high-grade dysplasia, not cancer, but it's like this is like a pre-cancer, significant precancerous state, then you have to repeat your scope in 3 years. The other scenario will be first-degree relatives diagnosed with colon cancer before age 60. In this group, the colonoscopy is done at age 40 or 10 years before the youngest diagnosed family member with follow-up every 5 years. Let me explain that a little bit. So if your family, let's say your brother, was diagnosed with colon cancer at 35, you have to start scoping from 25. You understand? All right. And after that scope, every 5 years, you have to do the scope. With respect to high-risk patients, it might be kind of far for you all to read, so I'll read it out. Due to hereditary syndrome or inflammatory bowel disease, the 2 main hereditary syndromes are familial adenomatous polyposis, which is also called FAP syndrome. And as I explained earlier on, this is due to genetic mutations in certain genes, and it's passed down from relative to relative, okay? Offsprings. So the gene affected, the main gene that's affected in FAP is the APC gene. Hereditary non-polyposis colon cancer syndrome, that is another genetically oriented or acquired colon cancer where the gene affected can be various. You can have a problem in the DNA mismatch gene. You can have a problem in the MSH6 gene, MSH2 gene. So there are various genes, once mutated, can lead to HNPCC. The ulcerative colitis and Crohn's disease, those are the 2 main inflammatory bowel diseases. And of those 2, the ulcerative colitis is the one that's more associated or of a higher risk factor for colon cancer as opposed to Crohn's. So suspected hereditary colon cancer patients should undergo genetic testing and counseling. So if you have a suspicion, what I'm saying is if a relative was tested and they are positive, or if an individual has a strong family history and you suspect that there may be a hereditary issue going on, they should consider genetic testing. Genetic testing is not available in the public sector with respect to any cancer. The state doesn't pay for genetic testing. It is available in Trinidad, though, privately. Some places more expensive than others. So patients who are known or suspected of having FAP, their screening colonoscopy starts from childhood, from as early as 10 to 12 years, until their prophylactic or therapeutic total colectomy or proctocolectomy is done. Why? Because these patients have a 100% penetrance, meaning they will definitely, at some point in time, get cancer. One of those parts, because their colon, you saw that one bump? When you do a scope, some of them, you can't even see normal bowel. They just have bumps throughout. You understand? That's how bad it can get, right? And they will definitely get that cancer at some point in time, and sometimes very early. Okay? So they have to get screened and looked at every year. Right? As it says there, yearly flexible sigmoidoscopy looking at the left side, and in some cases, yearly colonoscopy until they have that operation. Patients with HNPCC, however, screening colonoscopy is also offered every 1 to 2 years, starting in early adulthood. So not until they're about 20 to 25, we start screening them, or 10 years earlier than their youngest immediate family when they got diagnosed with cancer. Patients with inflammatory bowel disease, they have screening colonoscopy, especially the ulcerative colitis. They get screening colonoscopies done with biopsies looking for dysplasia every 1 to 2 years after 8 years of pancolitis or 12 to 15 years of left-sided colitis. So ulcerative colitis starts from the rectum and moves its way up. So it starts from the end, moving upwards. So you could have a situation where only the left side is affected and the right side is good. Pancolitis means the entire thing is affected with the ulcerative colitis. So, yes, the talk this evening is mainly on awareness of cancer and with stressing on screening so that we can find the cancer before it actually reaches cancer, right? That being said, there are many individuals who, when they go to do their screening, they find the cancer because many cancers don't pain. You don't know it's there, and it's there. You understand? So you may be fine, and you go to screen, and what you find is cancer. You go hoping to find it if it's there before it turns cancer, but sometimes it's cancer. I.e., a patient can present with asymptomatic cancer, right? But at least many times in that situation, it's still early. Most likely it hasn't spread to any lymph node yet. Most likely it hasn't spread to the liver or the lung, etc., right? And once that is the case, we can be using words like cure. So a patient might have gone for a fecal or cord blood test and they find traces of blood in the test, and you do a colonoscopy after, and you find a cancer, right? A patient may have a change in the bowel habits, so it's important to pay attention to these things. You usually go every day, and for the past month, I find 2 days passing and I ain't going, and I had a strain. What's going on? I'm eating good still, I'm doing what I'm supposed to do, I'm drinking my water as usual, but I'm straining. You need to get scoped. When you see you start having symptoms, forget about all the other tests on them. You need a colonoscopy. It is no longer screening. It's now diagnostic. You understand? Okay. And I explained the difference between diagnostic and screening earlier on. Rectal, you're passing stool and you're seeing blood. You need to get scoped. Decrease in the stool caliber. Most likely you have a left-sided lesion, so it's narrowing, and the stool not coming out as big as it used to before. It's more like a pencil now. You need to get scoped. In advanced cases, sometimes it might differ depending on the location of the cancer. But basically, these patients will present with fatigue, weight loss, iron deficiency, anemia, especially if the lesion is on the right side, and in some cases, abdominal pain. When abdominal pain starts, things bad. It's relatively late. Right? That means the cancer going through the wall of the intestine and interfering with the peritoneal lining, where the nerve endings are, on your abdominal wall and so on, and causing pain. Either that, or blocking up the lumen of the intestine, and it can't go off properly, and it's getting obstructed. That could cause pain. Right? So how we do the workup? We went through a lot of these things earlier on in the breast cancer patient, for example, where you identify medical comorbidities of the patient. Comorbidities meaning other illnesses they may have, because sometimes you may have to address those things either before or simultaneously to make sure that the patient comes out of the invasive aspect of their treatment, which is most times an operation, if you want to cure them. And you want to make sure that they come out of the operation well. Okay, it makes no sense you take a patient who is frail and can't tolerate the operation to go and remove the cancer, and then they don't wake up from the operation. That ain't making sense. I always say, I'm here to do good, not bad. You understand? If I can't save you, I prefer the disease kills you rather than me. You understand? Yeah. So family history is important, so you can get an idea of how soon you need to do their follow-ups. Complete colonoscopy with biopsy. Sometimes we do tattooing of the area of biopsy, because the way I remove these lesions is laparoscopically. I no longer do a big cut in the belly to remove colon cancer. They all get done through minimally invasive surgery with ports. You put about 3 ports, and that's how the operation is done. And you make a small cut somewhere along the lower part of the abdomen. You don't even see it, right, to remove the specimen. And it doesn't matter what part of the colon has the cancer, it can be done via that method. Okay, CT scan of the abdomen and pelvis is a must, because that is how we stage the patient to see where the disease has spread to, okay, from radiologically. In some cases, we do a chest x-ray. All cases, we do a chest x-ray. If something is found abnormal in chest x-ray, then you do a CT of the chest. If the cancer is in the rectum, then they should have CT of the chest as well. Why? Because the blood supply of the rectum and the blood drainage of the rectum, it enters the systemic circulation faster than with the colon. So you could actually end up with spread to the lung before you get spread to the liver if you have a cancer in the rectum, as opposed to having the cancer in the colon, where most likely it's very unusual to have spread to the lung before it actually spread to the liver. a baseline CEA. CEA is a tumor marker. And as I reach this point, I'll deliberate a little bit on tumor markers. Tumor markers are neither sensitive or specific. So people who have friends in the lab and they're going and doing a whole set of tests, that's wasting reagents and wasting your time, because those blood tests are not screening tests. Notice all the screening things I went through, I mentioned one blood test to screen for nothing. The tumor markers have its place. They are used when you're already diagnosed with the cancer. We do a baseline sample to see what it is. And after we remove the cancer, we do another one to see how it has improved. If it's still elevated, it could mean that the resection was inadequate. Or if it goes up later on, it could mean that the cancer has come back or the disease is progressing. So that is where we use it to follow. That being said, there are some illnesses, some cancers that tumor markers are considered in some situations for screening, such as prostate cancer. Your doctor might say you need to do a PSA. Some may say no PSA. What is established for screening for prostate cancer is a digital rectal examination where the doctor does that every year from when you turn 40 to feel the prostate. That is established. The PSA is neither here nor there. CA125, that's another tumor marker that's used for ovarian cancer, but it's not an established screening tool, right? Surgical resection. Surgical resection is the foundation for curative treatment. If you can't cut it out, you can't cure it. No cancer. If you cannot cut it out, it cannot be cured. You cannot use terms like cure. If there's a reason why you're not a surgical candidate to remove it, you have acquired the nomenclature of palliation, palliative treatment. You may go on medical therapy, and you may do a scan, and they may see nothing, but you still cannot say, I have been cured. You are in remission of the cancer. You understand? All blood-borne cancers, there's no cure. Leukemia, lymphoma, all these things, but they respond well to chemotherapy. So you can end up living a full life, but you're not cured. The only opportunity of cure is if you find the cancer early enough before it has spread so that you can remove it. That is the only time you can get cure. All right? Screening is important. I'll pass that. So this is the diagram I was talking about. It's the same diagram, but a little more colorful than the other one we were looking at, right? And you could see where the different segments of the colon and the rectum and its blood supply. Basically, where the blood supply runs to the segment of the colon, the lymphatic vessels and the veins run away from the colon along that same trajectory. So when we do a cancer operation, we resect the segment that's associated with the cancer, whether it's on the right side, you remove the whole right colon, the left side, you remove the entire left colon. If it's in the sigmoid colon, you remove this entire sigmoid colon. And you take that blood supply sheet of fat with vessels and nodes going all the way to the origin of the blood supply to that segment. Right? It's important to do that because the pathologist is going to be looking for certain things, including lymph nodes. So if you just stay close to the bowel wall, you're not going to get the lymph nodes. And if the patient has had all the characteristics of the cancer to avoid chemotherapy, because the pathologist didn't get any lymph nodes, he has to assume, or the oncologist, the medical oncologist, has to assume that you probably had positive lymph nodes and treat you with chemotherapy. Whereas if those nodes were removed, and they need to see at least 12 nodes. If those nodes were removed and looked at under the microscope and there's no cancer in them, once the cancer in the bowel is favorable, you can avoid chemotherapy. Because remember I said, chemotherapy not easy, right? But sometimes it's a necessary evil, right? So with that, we come into the end. A few take-home points. Cancer kills, and we are all vulnerable. Okay? Early detection and treatment saves lives. Herbs don't work. Herbs don't work. Okay? You go to the herbalists, especially the ones who have the established business, right? You go to the herbalist, and they will tell you, yes, man, you come to the right place, and they treat you with all kind of thing, ozone this, and that kind of water, and this kind of water, etc., etc. When water more than flour, and you go back to them, they say, Miss Lady, I'm sorry, we can't help you now, you need to go to the hospital. Those are the cases we see. And by the time they come to us, it's too far gone, and you're suffering. So don't do that. Don't do that. I don't know what we can do in this country to shut them down. I don't know what to do. If people could come up with ideas, they should probably put it out there, because they're really doing an injustice to our population. And we have intelligent professionals who get diagnosed with cancer, and they go in that route. So, anyway, a little passion there. Don't let the fear of knowing deny you from early detection and treatment. Okay? It's worse not knowing. You're going to suffer more later on. Go and get tested. You get tested, good, fine. You go tested, they find something, all right, at least it's early. You understand? And you deal with it. Don't go and get tested, they find something, and you're afraid to continue. Follow through, right? Please get screened. And thank you for your attention. The gentleman in the yellow jersey.
Here is my question. There's no herbs can work for kidney at all? No kind of herbs if your kidney is sick? Like
We're talking about cancer. Eh?
I know.
That's the topic.
But
No, there are herbs for different things. I cannot advise you on herbs because I didn't study it.
so there's no herbs for
My
cancer.
introduction to herbs was limited because in Cuba medicine is how to put it, because of the embargo and so on, they're very limited in terms of things they can get.
Okay.
And they are very innovative.
Okay. One more.
And just let me finish answering your question. And they have gone to using other alternative medicine methods, which includes herbs, but they do it on a more scientific manner. So they will study these things, and they will have literature on what works for what. You understand? And they use it because of their need. So you know they say necessity is the mother of invention. So that's a situation where they need to do that. You know, they even embark on Chinese medicine with acupuncture and seed therapy, etc. And those things have its place because the science will show you where the needles stimulate nerves that release endorphins and so on. So those things work, you know, to an extent. But they don't work on cancer.
Last question. The finger test for the prostate and the blood, does it work? Does it real or it's not? You have to take something else. That's all.
It works. Once the doctor is experienced and understand what he or she is feeling when they do the digital rectal examination with respect to how the prostate is supposed to feel, if you have something there, they will find it. In that case, it's not really, it is screening, but you're not going to get the problem in a precancerous stage. By the time you find it, it's because you have cancer in the prostate already.
Thank you.
Okay. Good afternoon. Can you just explain 2 questions, please?
Sure.
What is aggressive B-cell lymphoma and diverticulitis? Thank you.
Aggressive B-cell lymphoma. Well, you know, you have different types of lymphatic cells. And it's just a term given for patients who have that type of lymphoma and it's spreading fast. That's putting it. And as I said earlier, lymphoma is one of the blood-borne types of cancers, and there's no cure. You can get it, they respond well to chemotherapy, right? But you can only go into remission. Surgery has a place, but only for making the diagnosis. We'll come in and remove a lymph node, send it a test, and that's how they confirm the diagnosis that you have lymphoma. Yeah. With respect to the other question, diverticulitis. Diverticulitis is an inflammatory process. It's not cancer. Diverticulitis comes from diverticula. So diverticular is an outpouching of the colon that occurs, and this is theoretical, when you have a diet that's poor in polysaccharides, non-starch polysaccharides. That means a diet poor in vegetables, fiber. So, but again, this is theoretical, right? If you don't eat enough fiber, the intestine has to work too hard to propel the stool along. And by doing so, where the blood vessels penetrate the intestine, it creates an area of weakness. And from all that work the muscle has to do, it pushes the mucosa outwards. And those are the outpouchings, right? Diverticular, you can live a normal life with diverticular and have no problems. But if it's going to give you problems, the problems can be significant. And there are 2 main umbrellas. One, bleeding. So where that outpouching happens, there's a vessel that goes in there, and when the hard stool rubs against the mucosa and exposes the vessel, it can bleed. The bleeding is significant. You can bleed so much, you go into the toilet and your toilet full of blood, and you can faint away. But the teaching is the bleeding stops as sudden as it starts, right? Some people, it prolongs. Most time it's because they're on medication that thin their blood, like aspirin and Plavix and those things. And many times they have no choice. They have to be on it because of illnesses that they may have. So it's like between a rock and a hard place with respect to the bleeding. There are times when things can be done to localize the bleeding and stop it. And many times we have to go in as an emergency and remove the entire colon because you don't know exactly where the bleeding coming from. Because most times, the entire colon full with diverticular. With respect to the itis, which is the question you ask, the diverticulitis is the infection part, so that's the other umbrella. When you have a little perforation in the intestine, you can get what's on the inside, and you know what has been on the inside? Going to the outside, and that's bacteria. So it causes inflammation, right? And that inflammatory process can be painful, and it can occur in different stages. So the first stage will be a peridiverticulitis, and that's where you could have pain and so on. Ideally, you get a CT scan done to make sure you don't have a collection of pus in the belly. That will require drainage. If that is not the case, then you're given antibiotics, and the infection will settle. Many times, that inflammatory process might be repetitive or recurrent. So you have bout after bout, you take antibiotics, it gets better. Sometimes you get in bouts of inflammation and you're not having pain, so you're not doing anything really. And it's healing itself because your body's amazing. It heals itself, right? The thing about it is, when we heal by forming fibrosis, fibrotic tissue, which is hard tissue. And that hard tissue could in itself compress the intestine. So you can end up with a stricture, which you call a diverticular stricture, and end up with an obstruction of the large intestine because of that problem. This little perforation I mentioned earlier, it can be bigger. It can be so big that enough stuff come out and the entire belly get full of pus. That's an emergency. You have to end up in the hospital, emergency surgery, make a big cut in the belly, suck out the pus, etc., wash it out. And most times, yes, you might be able to remove the segment, but many times you have to end up with a bag where you bring the colon out on top because it's too unsafe because of this, because of the contamination. It's unsafe to join it back because chances are that joining will not heal. You understand? So you don't want to join it back and then you close up and you go, and then 2-3 days down the road, it opens and you're leaking inside again. That is trouble, right? Trouble on top of trouble. So in that case, you put the bag, 6 to 8 weeks down the road, you're better, everything is much better, you go back for another operation, and at that point, you join it back. So the bag is not permanent, right? So the bag doesn't necessarily have to be permanent. It's just a means of buying time, okay, to make your outcome successful and safe. I don't know if that answers the question. Okay. So we went away from cancer a bit there.
Good afternoon.
Hi.
I would like to know, we have breast cancer, colon cancer, plenty different cancer. What cause cancers?
Oh, this lady came late. That was at that was at the beginning of the talk. So okay, so I'll repeat. The cancers are caused by genetic mutations. Genetic mutations that can be acquired from hereditary means, where it passed down from your family line, your germ line, or from the environment. And these mutations cause cells to multiply at a much faster rate and form a tumor. These tumors can become invasive and find their way into lymphatic vessels and blood vessels, and that's how they travel to other parts of your body, and they interfere with the function of those organs when they go there. And basically, that's how it is. There are more, a little more, that's putting it simply, okay? There are two main genes, as I mentioned earlier, proto-oncogenes and tumor suppressor genes. So the proto-oncogenes, they promote growth, and the tumor suppressor genes stops growth. If there's a mutation of a gene that makes a proto-oncogene work more, you can get a cancer. If there's a gene that could affect the tumor suppressor gene from stopping growth, then the tumor suppressor gene cannot do its work. So normal cell replication just goes away and continues replicating and becoming more and more until it takes over the host organ, basically.
Good afternoon. Now, I have two questions. Now, with colon cancer, you say, I should ask the first one. What is the length of your colon? And since I see that different sections of your colon. Now, if you have colon cancer, can it, as you say, you have to cut it for it to be cured, right? So if we catch it early, when you cut it, could it be reconnected?
Yes.
Oh, okay.
There was a slide that I passed over kind of quickly where I guess I could probably go through the slide then based on that question. Surgical resection. So this slide will explain that a bit. About the length of the colon, it's about 5 to 6 feet long, depending on the individual. As I mentioned, so the foundation of curative treatment is surgical resection, right? And 75% of patients are potentially curable. 10 to 25% of patients may actually have mets to the liver. Mets means spread to the liver, and those patients are not considered curable, but the disease can be controlled by resecting the lesions, whether it's at the same operation or at a later date, or whether you give the patient chemotherapy first and then you go and do the operation after and remove the lesions, and the disease can be controlled for years on medical therapy. The goal of the surgery is to achieve what we call an R0 resection. An R0 resection means when you resect the bowel, the pathologist looks at what we call the margins, or for you to understand, the borders of whatever you resected. So they look at it under the microscope, and they want to see that there are no cancer cells at these borders. One has to assume that because the edges had no cancer, there's no more cancer in you. We remove it all. If the edge has cancer under the microscope, we have to assume that they still have cancer inside of you. So the aim is to get a R0 resection. I mentioned that a minimum of 12 lymph nodes is necessary, and bowel continuity should be restored always when possible. This is the question you're asking about joining it back. So in most cases, when we're going to do a resection, we join back the intestine immediately after. Immediately after. Okay, regardless to where we're resecting. There are some situations, for example, if you look at the rectum there, if you have a cancer that's very, very low in the rectum, close to the anus, right? Sometimes it might be very difficult to join you back. You understand? And we will have no choice but to do what we call an abdominoperineal resection, meaning through the abdomen we do the dissection and we resect the rectum all the way down and close up the back there. And in that situation, you have a bag forever. But you have life. And you don't have pain. You understand? Exactly. And nobody know your business. It's only you and God. Nobody know your business. You understand?
So there is no anal reconstruction?
No. They ain't doing that yet. Maybe that is one for the future. You use AI and things to recreate a mechanical anal canal. Yeah, Any other questions?
Good afternoon, everyone. Good afternoon, doctor.
Good afternoon.
I was diagnosed with Crohn's disease a couple of years ago.
Sorry to hear that.
Is it something hereditary, or is it like something where you're born with?
There is a familial predisposition, yes, but I don't think it is I can't say 100% that it is indeed hereditary. There are some people who end up with Crohn's disease and they have no family history of Crohn's disease. I can't say you were born with it, because I'm sure, as you say, how old are you now, if you don't mind me asking? And it only showed up when you were 60? 40s, right. Therefore, you couldn't have born with it. Because if you're born with it, then from baby, you'll be having issues. Yeah? So it's more acquired rather than congenital. Congenital means you're born with it. Acquired means you get it as life goes on. Yeah. So Crohn's disease is one of the inflammatory bowel diseases that I mentioned earlier. The ulcerative colitis is more associated with the cancer than Crohn's disease, but Crohn's disease can also be a predisposing factor for getting colon cancer. So I'm sure your gastroenterologist will advise you of how often you need to get screened and so on. And the difference with ulcerative colitis is that ulcerative colitis only affects the colon. Granted, you can have other extraintestinal situations taking place, things taking place, but in ulcerative colitis, the main issue with the colon is just the colon. Crohn's disease, on the other hand, can affect you from your mouth to your anus. The entire gastrointestinal tract can become affected with something or the other. You understand? But most times with medication, it can be controlled. Yeah.
Good afternoon, Doc. One question I want to find out is that how come when people doing tests and they go through, you call it, for instance, if you have cancer, right, and you go through treatment, how come most of the time people die, you hear this, at the last stage is always stage 4 cancer. So what happens during all that treatment you're taking before you hear the last stage is stage 4? Right.
That's a good question. Sometimes when you hear the rumors, you may not know the full picture. And there are multiple scenarios that can explain that. A patient could present, and initially they are stage 1 or stage 2, depending on a lot of different parameters that we use to get to a stage. Let's say breast cancer, for example. And you receive treatment, and the biology of the cancer might be such where you are required to have chemotherapy, and you are required to take the tablets for 5 to 10 years, and so on. And then 5 years later, cancer show up again somewhere else in your lung. As I said, once the cancer spreads from the original organ to a different organ, it's considered stage 4. And that is one way you'll say, well, they say I have stage 4 disease now. Once you have stage 4 disease, it's not curable. The treatment at that point in time is to make the patient comfortable. Still treat the cancer to keep it as best as we can with medical therapy, not surgical therapy. There are some situations where we embark on surgical therapy, but those are few and far between. So I'm not sure if I answered your question. So basically, initially your stage wasn't stage 4, and eventually it became stage 4. That is the natural history of cancer. You will never start off at stage 4 unless it's a blood-borne cancer. You're going to start off at stage 0, 1, 2, and so if you do nothing about it, you will eventually get to stage 4. And there are some situations where you're getting treatment, and despite the treatment, you're still progressing because you also have progressive cancers. As the lady mentioned, aggressive B-cell lymphoma. You could have aggressive breast cancer. You understand? So we look at different things in the breast cancer. For example, you have grade 1, grade 2, grade 3. Grade 3 with a high Ki67 proliferative index is aggressive. You understand? And cancer tends to be very aggressive in young people. Young people are not supposed to get cancer. That is why you acquire this average risk when you reach 40 and 50 years old. You understand? When young people get cancer, most times it's an aggressive cancer because they weren't supposed to get it in the first place. So it's some problem that took place that made it happen.
My next question to you is, Doc, let's say you have a patient that came in at stage 1, and you treating that patient, and somewhere down the road, you tell the family, your family has stage 4. So what has happened between from 1 before it reached 4, and you are the doc that treating that person's family?
Right, we see, when you say treating, you have to elaborate on what treatment you're talking about, because if a patient comes in with stage 1 cancer, it depends on the type of cancer, 1. You come back with stage 1 cancer, and the treatment intent for a stage 1 patient has to be curative. Okay? So your intent to treat the patient is curative, i.e., that patient needs to get an operation to remove the cancer. They may also require, or may not require, certain types of medical therapy as well. Okay? But there are times when you come in, and in the initial stages, it appears to be stage 1. But that person could have what we call micrometastasis that already got into the bloodstream, and it's just circulating there, waiting for the opportunity to implant on another organ. And you end up with stage 4, despite all the treatment, all the curative intent. You understand?
So when does the cutoff point come? For instance, like my father, right? He was a chain smoker, right? He died from lung cancer. And
so that is
it was so nice.
An environmental factor, which is modifiable, and it's up to the individual to stop it or not.
It had reached a point where it was so bad that some doctors were so honest that they told my mother, it doesn't make sense spending that money to do the operation because his lungs is already gone, right?
But what was that operation?
Maybe to remove his lungs, I don't know. You understand? I was young at the time. But the good thing is the doctor was so honest to say that, Mom, at his age, it doesn't make sense to do that operation. Let him enjoy the rest of his life because he's still going to die. My question is, some doctors carry it from stage 1 all the way right down, and in the last stage, you will say stage 4. I don't understand.
Yeah, but it's very difficult. It's very difficult to be able to predict what the future holds, you know.
No,
You can't see a patient and who is potentially curable by offering them the treatment that they require based on their stage and say, well, it's possible that you might go on to stage 4 and die anyway, so why don't you just stay with your cancer and whatever? You understand? That doesn't make sense.
The next question is, why some doctors recommend chemotherapy and most people who take
Recommend what?
Chemo.
Chemotherapy.
Most times they don't ever live through that. I just don't know. I just asked the question.
Yeah. Right. So a doctor wouldn't recommend chemotherapy unless it's indicated. Right? Based on the type of cancer, the grade of the cancer, the stage of the cancer, the biology of the cancer. Because they will be medical legally liable if they do, right? There's science behind it, And if the patient is a patient that fits the criteria for chemotherapy as a part of their management, that is what the doctor will offer. Not everybody fits the criteria for chemotherapy. So not everybody gets chemotherapy. The few people who you know with chemotherapy may have died. And most times when somebody's getting chemotherapy, it's because it's an aggressive cancer. And chances are they may die from the cancer. You understand? It might just be a matter of time. It might be 6 months, 3 months, 6 years, 10 years, who knows? There are times when you have a very good idea. I tend not to give death sentences. Right? I don't give death sentence. I will say the prognosis is not good. Expect the worst. But, hope is always good to have. Try to be happy. Try and live your best life. And,
Come on, put your hands together for Dr. Bascom. The audience is asking if you're willing to share your contact information or whatever. We can discuss that after, if you
Sure.
want to, or where we can get further information based on a true story. Let me just say, Dr. Bascom, he probably can't even remember, but my mother had stage 4 cancer. And I guess my niece could probably tell the story better than I, because I was abroad. And the consultant was asking that my mother do a surgery for X amount of thousands of dollars. He even asked if he had family abroad, to pay. And I was living abroad, and I'm happy to say that Dr. Bascom, I think he was probably maybe an intern or something in that area. He intervened and he spoke to my niece and told her, your mother is already at stage 4. Don't go and do no surgery, to waste that money, carry her home and give her palliative treatment and whatever. And we did take our mom home. I did come back in time, and God is so good that God gave my mom a year and a half in remission. She just came up, got better, everything for a while. Amen. And so we were able to give her a final farewell, and I was truly appreciative of that, because we would have been spending money for a surgery that she really didn't need, given her condition and her state. Right? And I think the surgery was even orthopedic. It wasn't even, cancery. So there has to be ethics in the medicine, and we're grateful that we have people who still have ethics in medicine doing the work. And so we are grateful. There are a couple of people from our church who are their doctors, so I wouldn't even say much, but and they spoke highly of you. So we are grateful to have Doctor. Come on, put your hands together one more time for. All right, so this ends the formal part of our session, amen, and it's grateful. We have food provided for everybody, amen. The men will be serving, so we just stand to dismiss. Thank you so much for coming out, amen, and it is very, very informative information, amen. It's online, so you can get, if you want to go back and get some of the pertinent information from our church Facebook page. Amen. All right, let's pray. Father, today we are so grateful for all the information that was shared, the knowledge that was so much, oh God, a benefit to us. We're grateful for Dr. Bascom and the work that he's doing in trying to help cure and to heal people as best as he possibly can with the knowledge that he has. We also believe in another healer named Jesus, who is able to work with the medicine, work with the knowledge to complete the work, even when the physicians are unable and they have written it off. God, you're still able to finish the work and recover. We have testimonies of many individuals who have been 12, 13, 14 years in remission, if, as the doctor would say, but we say they're cured in Jesus' name. And so, Father, we thank you for the opportunity to learn and to receive. So bless your people today. Bless the food that has been provided, and let it be nourishing unto our bodies today. Thank you for all those who made the effort to be here. And we give you thanks and praise in Jesus' name. Amen and amen. All right, so the food, you will, the instruction is the men we serving in the back, ladies first, and then men after. Is that all right?